spine surgery live for you, our audience on YouTube, Facebook, LinkedIn, Twitter, and maybe one more platform. Today we're going to be performing surgery on a patient's cervical spine. Cervical spine is located within the neck, and there are 7 bones or vertebrae, and in between them are discs. This patient has 2 discs that are herniated and degenerated. She has herniated, degenerated disc spondylosis with stenosis, neck pain, radiculopathy. That is the number 5, 6, and 6, 7. All right, so if we look at the x-ray from the side view, and we'll be using an x-ray machine in the operating room called the fluoroscope, 2, 3, 4, 5, 6, 7. So you could actually move up a little bit because you're overexposed because you're penetrating the shoulders. You don't need to be. We're going to move our fluoro north about 1 inch. Shot. That's good. And Flynn, make sure you flip over to the x-ray picture so the audience can see. Now we're doing a right side of the neck approach. If you look at this here, can you see the patient here? Her face is covered. She has a tube in her throat. It's called an endotracheal tube. It goes down and it's ventilating her lungs. And this is the front of the neck on the right side. And this is where we're going to go in. Okay? So, without further ado, shot. 2, 3, 4, 5, 6, 7. Looks like I'm sitting right above 6, 7. You agree? Monica? Yes, sir. All right, so I'm going to come south. Luis, yes? Shot? Yes, sir. Yes, sir. Shot? Perfect. Let's get let's see. Give me a shot and then an AP. AP quick. So the nice thing about this patient's neck for me as a surgeon is it's thin and her spine is anterior. That looks pretty good. Give me an angle. No, rotate it south. This south. Yep, shot. I want to see where the tip is. All right, that didn't really help me. It looks like we're a little off to my side. So go back to a lateral. Now we show you the surgery unedited live because we want people to see how this type of surgery is done. And we're really not trying to hide anything. We want people to see, shot, even when we have problems, exactly how do we deal with the problems. Okay, there's no point in teaching people about surgery if you don't show them the issues that occur during surgery and how we resolve them. So 2, 3, 4, 5, 6, 7. I am at the front of the C6-7 disc. I just want to check an AP x-ray, make sure I'm in the midline, which I am. It's perfect. So I'm checking 2 views, the front back and the side to side. The front back's called AP, and the side to side is a lateral view. You can see the needle is sitting at the front of the disc at C6-7. So I'm going to enter that disc now that I'm confident I'm in the right entry point of the disc. I'm going to enter it and go deeper. Shot. I feel myself inside the disc now. And at this point, what we want to do is something called a discogram, where, shot. Perfect. And what we're doing is we're injecting 2 types of dye. One is contrast dye, so we could see the inside of the disc and the tear in the back with the x-ray. The second type of dye is a blue dye, the Deuk spine dye, and that stains the herniation. Shot? All right, there you go. So you can see from the dye, which should normally be looking like a little cotton ball in the middle, it's actually leaking out the back. AP. We're going to get a front to back view. Shot. There we go. Now just stay there for a second. Monica, show our audience where the tear is in the back of the disc. Monica is going to use her little arrow and she's going to show you the tear in the back of the disc. Are you moving your arrow? Yes, I don't see the arrow. No, you're on the wrong picture. It's the AP view. Yeah, so show them the tear. Go to the tip of the needle. There's the tip of the needle. It's right there. See that black line to the right of the tip of the needle? That's the tear. And now to the left of it. That's the other tear, okay? And you can see, show them the dyes leaked out around the nerve root there. That's the nerve root. That's what she's showing you with the white arrow. Can you see that, Flynn? I hope you can. That's the dye leaking out through the tear into the neural foramen around the nerve root on the right side. Okay, let's go back to a lateral view. The other thing you can see in that AP X-ray is the endotracheal tube, the esophageal temperature probe, and EKG lead. Those are the wires. All right, so far we're going through the front of the neck. We're in perfect position for the Deuk laser disc repair, and that's the name of the surgery we're performing today. Shot? Yep, good. This surgery is called the Deuk laser disc repair, and it's an endoscopic surgery done to repair a herniated or degenerated disc and get rid of the pain people have in the neck from the disc, to get rid of the headaches that herniated discs cause, and to get rid of the arm symptoms like numbness, tingling, and weakness. We call it radiculopathy. The more traditional way of fixing this that most surgeons know how to do is called an anterior cervical discectomy infusion. It's a much more invasive surgery. It causes scar tissue, bleeding, trouble swallowing, hoarseness, and then of course you're fusing bone, so you're losing movement. The patient's losing movement. It's a much worse surgery. It has a high complication rate. And this surgery, though, is endoscopic and laser. There's none of those problems with scar tissue, bleeding, infections, none of the complications with typical ACDF surgery. Shot. Now I'm going to remove the guide wire. I'm going to leave the guide wire, remove the needle. I've already made the incision. It's 4 millimeters long. Shot. Now, 4 millimeters is pretty small. You can't do an ACDF surgery or an artificial disc surgery with a 4 millimeter incision, but you can do endoscopic spine surgery with a 4 millimeter incision. That's why we do endoscopic, is so you can make the incision small and the patient doesn't have complications like they do with artificial disc surgery or fusion surgery. Shot? No thanks. We're coming down onto the C6-7 disc from the front. We're using the dilator. Shot. I'm sitting on the front of the disc now. And again, I want to check my AP view just to make sure that the dilator tip is in the midline. Now, you're never going to be exactly in the midline, but you should be close. And if you look there, show them, stay there, and show them the spinous process. You don't have to take another shot. Just go show them. We're going to use the white arrow. Flynn, you should be on that AP X-ray. There's a spinous process. Circle it with the arrow. Perfect. Now show the one below. Now draw a line between the middle of the two spinous processes. That's dead center where she's showing you. It's actually, there's kind of a wire there already. No. To the middle. There you go. Yeah. Now look at the tip of the dilator. The dilator tip is pretty much almost exactly on the midline. As a matter of fact, we're just a little bit to the right side of midline, and that's fine. The width of the spinous process, show them the width of the spinous process. From about there to about there is a very safe area to have your dilator. Enter the disc. All right, thanks. Go back to a lateral. At this point, I'm happy with where my dilator is, and I'm going to enter the disc. You can see that how small the incision is here, right, Flynn? 4 millimeters. Now I'm going to start entering the disc by just gently pushing the dilator in through the anterior longitudinal ligament. And once I get it entered into the disc, now like I am now, I'm going to take my guide wire out and I'm going to advance this dilator the rest of the way, shot, using my mallet. Some people freak out when they see the mallet, but the mallet is a very safe way of delivering force to the dilator. Shot. 2, 3, 4, 5, 6, 7. Everyone agree we're at C6-7? Shot. All right, I'm at the back of the disc now. Shot. And I'm going to advance just a little bit more. And notice that the dilator is also opening the disc space, especially in the back. That's where we want it to open the disc space. This is wonderful surgery for people with osteoporosis or osteopenia because we're not fusing, we're not putting a metal implant, we're actually doing a natural repair of the disc. The Deuk laser disc repair cures around 98% of the neck pain that comes from a herniated disc and about 98% of the arm weakness, pain, numbness, tingling that people get in their arm from a pinched nerve. So with results like that, you don't get those results with ACDF or with artificial discs. Artificial discs and ACDF usually report around an 80% improvement rather than a 98% improvement. Shot? So the results with Deuk laser disc repair are better than ACDF fusion and artificial disc. What is it?
You want to remind on this one?
Yeah, we can do a little inline traction to help, a little shoulder pull,
Please.
a little arm pull, and inline traction, just straight inline traction with slight extension. When you guys are ready.
Slowly. Yeah.
Not too much, just a little bit.
Just a little bit.
All right.
Thank you, sir.
So what we're doing is distracting the disc space because it is a degenerated disc shot. And by pulling on the neck, slight extension, it's going to help get the tube in. Shot. Watch the tip of the dilator for me, Luis.
Let's go.
Almost done, guys. Keep pulling just a little bit more. Almost there. Shot. That's nice. A little bit more, just a little bit more. I want to get another millimeter. That's probably as good as we're going to get. Good. You can all relax. So, unlike anterior cervical discectomy infusion or artificial disc, the Deuk laser disc repair is minimally invasive. There's no metal, so you don't have to worry about fusion, and you don't have to worry about bones fusing or fractures of the bones, or failure of the hardware, like screws getting loose or breaking, or the metal plate slipping, or the cage fracturing. Really. Flynn, why don't you show our audience how the Deuk laser disc repair works? Let me see.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. Better?
Yeah, but it's not moving.
Still not
It's dark
capturing
there,
it.
but
All
it's-
right, come out. So right now we're trying to, the mouth of this is bent a little bit, and we're trying to repair it
Monica,
on the fly.
no, you're good.
No, not yet. Let's see what we can do there. All right. Well, let's see if we can get the scope in. If not, we'll have to change out the tube. That may be the problem, why I'm having a stuck tube.
Yeah.
Is those flanges are, what do you call it, bent in. You know what I mean? You know how I complain about it a lot with the cervical?
Yeah.
That may be the issue.
Yeah.
All right, so we are now seeing through the tube the back of the disc, and that tube is internal diameter is about 3.2 millimeters. So think about how small that is, folks. That's tiny. You can see the disc herniation right here. There it is. There's a piece of it right there. See how easy that is? What I do is I basically bring the tip of the tube right to the herniation, and we leave the rest of the disc alone. And that's why we're able to do this surgery, is we're not removing the entire disc. We're just removing the herniation. So people ask me all the time, how much of the disc are you removing? I'm removing zero. None. There's a piece of herniation. So far that's 2. Guys, it's a little bit overexposed. If we can turn the brightness down a little bit. And you can see another herniation there and another one there.
On the top. The top. There you go. Perfect.
I think maybe that's good. Let's see how that goes.
Thank you.
All right, what we're seeing, not just the herniation here, but you can see the end plates of C6 and C7. That end plate there is probably C7, and the end plate up there is C6. And this is the space between the vertebral bodies at the back of the disc where the herniation is. So Flynn, we're talking a lot about the difference between Deuk laser disc repair and, say, fusion surgery, Acdf. Why don't we run our video comparing the Deuk laser disc repair to Acdf fusion.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a ½ inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
Welcome back. We're making really good progress. For those of you who don't know, the laser fiber is the little glass rod you're seeing at the top of the screen at 12 o'clock, and it delivers laser energy right to the back of the disc where the herniation is, and that's a bone spur right there I'm removing. We've already removed a lot of pieces of herniation. There were at least 10 that I've removed so far, and I'm going side to side because this patient has symptoms in both arms. Whoop, it did it again. You hear that? Yeah.
Same thing. Listen,
Same thing.
I need another scope. Can I have
Let's get another scope.
Okay, just break in and yeah, please. Have it. Thank you. Thank you, buddy. I'm sorry. Anything else, please? Thank you.
So right now we have to there's a laser fiber and it has a small tear on the side of the blue casing, and it's not safe to proceed with it. So we're going to fix it, and it takes a few minutes to do that, and then we're going to start up again. I'm not going to close the valve. That's what I'm going to do, which doesn't allow me to create as much back pressure, which I like. But let's just try it with the valve open until we get the next scope. But definitely we're going to need to get in there. Let me do it if you can't do it. Let go. Huh? Yeah, you know why. I mean, what's happening is it's scraping. So I'll leave the valve open. Hopefully that'll give us a little bit better functionality. Scope on. All right. So back to the laser. You can see there's a herniation still right there, and it's not coming out easily, so we're gonna just blast it with the laser. The laser works by delivering a lot of energy to tissue, and then that causes the covalent bonds that hold proteins together to rupture, to break apart, and that allows the tissue to basically break apart into small pieces. That's why you can take a big piece of herniation and turn it into a couple of small pieces of herniation. It's kind of like shooting a laser beam at an asteroid, and it breaks it up into little pieces. All right. Now the crack you're seeing down there in the middle, that's actually the space between the back of the vertebral bodies, and there is a herniation. You see it came out of the foramen right there. And basically, I'm just going to keep using the laser to remove as many pieces of herniation as I can find. At some point, I'm going to have them all removed, and you're going to end up seeing what's called the posterior ligament, posterior longitudinal ligament. I'm a little bit overexposed still, guys. Can we bring the brightness down?
The arrow. Yeah, please. Yeah.
Yeah, thanks. A little more. Yeah, that's better.
Thank you.
Yeah.
Thank you.
If you have the light up too high, what happens is everything looks white. So it gets very hard to tell one structure from another. And you want to be able to see what you're doing, obviously. You're operating just above the spinal cord and nerves. This is where the nerves live, out here in the foramen. You can see just a few pieces of herniation still stuck down to the posterior longitudinal ligament. They're really not pushing on the nerve anymore, but it turns out most people's nerve symptoms are not due to pressure, they're due to chemical irritation by these little pieces of herniation that are stuck in there. Flip it. So far, so good. Remember, we are still on the first disc that we're fixing. We have found that most patients need 2 discs. As a matter of fact, my paper that we published shows 2.4 discs on average per patient. That means if we were to fix the discs that are causing patient symptoms properly and get a 98% elimination of pain, then you need to treat more than 1 disc on average. So what it means is that most people with neck pain from a herniated disc have more than 1 disc causing their neck pain or their arm symptoms. They have an average of 2.4, according to my publication. So it's very common for us to do more than 1 disc surgery. And this patient here has 2 discs that need to be fixed. And this patient has another condition, as a matter of fact, that we haven't even talked about. I can't give away her identity, but I can tell you that she has more than 2 disc problem in her neck. She has another condition called C1-C2 Instability. And for those of you who don't know what that means, it means that the C1 and C2 bones, when they move, they create tremendous pain. That's usually pain up against the base of the skull. No, we're okay. Pain up again, I think it was the irrigation. pain up against the base of the skull. So that requires a different kind of surgery than laser. We're not able to fix that problem with laser. She knows that. She knows this surgery is just to fix the disc problem, but that she's also going to need a second surgery to fix those, the arthritis at C1 and C2 that's causing instability. And the problem is that surgery requires a fusion of C1 and C2. So that's a completely different type of surgery. Now, for those of you who like watching fusions, we are going to be doing a cervical fusion in a few weeks on the 26th. It's called an Acdf, or anterior cervical discectomy infusion. And that patient actually has possibly going to need what's called a corpectomy of C4, where I have to drill away the vertebral body of C4 because there's a herniation that just came out. You guys see that? I'm going to have to go after it. All right. So we may end up doing a C4 corpectomy during that surgery. That's a bone spur right there. People ask me, can a laser take care of bone spurs? Well, look at that. Sure can. There's a little piece of herniation zipping around everywhere. I need to get rid of that. So on the 26th, if you're around and you want to watch us do an outpatient Acdf, possible corpectomy, another bone spur right there, you see that? That's what, look at how the laser just vaporizes bone spurs. No problem. Lasers are designed to melt steel. So melting a bone spur away is easy. There's a lot of myths about lasers, you know. If you go out and read on the internet, there's a lot of things that are not true. People try to debunk the use of lasers in spine surgery, but lasers are being used more and more in healthcare, especially in surgery. We use them in neurosurgery quite a bit now for minimally invasive brain tumor surgery. They're used in spine surgery for minimally invasive spine surgery. There is no way to do endoscopic surgery or really minimally invasive surgery without lasers. All the most minimally invasive surgeries done today in the neurosurgery and the spine use lasers. So the problem is that most neurosurgeons don't know how to use lasers, and they don't know how to do endoscopic surgery. So they end up telling their patients not to get it done because, of course, they don't want to put themselves out of business. But the reality is that laser is the best way to fix herniated discs and a lot of brain tumors. All right, we're done with this level. I'm going to flip around and just do one more check. But you can see something too. As I move the tube, look at the bones and how they move. Look at that. So we've preserved motion here. We're not fusing. We're not putting any metal in. But we're able to keep the movement that the patient has at those bones. You see that? So we preserve rotational movement. We preserve displacement. We're done. Now we're going to move on to the next disc, which is the C5-C6, which is the next one up. So stick with us. Flynn, why don't you show our audience a video of a patient who's had the Deuk laser disc repair done on their neck. And let's have them see some of the results of this type of surgery.
1 second.
I think the laser is the best thing out there to have with this type of surgery. It's all legit. That's all I can say about it.
Dr. Deuk Machen here at the Deuk Spine Institute. I'm with one of my patients who's traveled to us from Mississippi, and he came here for the Deuk laser disc repair to be done for a herniated disc on his neck. and he's now here today, just one day after surgery. How are you feeling today?
Feeling great. Feel like the weight of the world been lifted off my shoulders. Feels a lot less pain in my shoulder, no more tingling. Feels like my body's trying to recover back to normal. I think the surgery went very well, no problem whatsoever.
And you're just one day after surgery. Can you tell whether the neck pain is gone yet?
The neck pain is gone, and the pain throughout my shoulder, the tingling, everything's gone. A little soreness in my throat. My voice is a little harsh, but other than that, I feel great.
Awesome. Can you show us your incision? Oh wow, look at that. So you have a 4mm incision. You can see that right here on the surgical footage of the endoscope. We actually, when you watch the video, you can see all the herniated discs back there. We were pulling them out one at a time. You had about 20 pieces. And then you can see the nerve root right there in the foramen. And there's no herniated discs anymore on the nerve root. We got them all out of there. I had to open up the posterior longitudinal ligament and get all those fragments of disc herniation out of the epidural space that were pushing on your nerve. And I got a good look at everything and it looked fantastic. So I think you're gonna do great. Did you consider having like a fusion surgery? Did anyone offer you fusion before?
Yes, I was offered fusion. I was told that was the only surgery that could be done. I started Googling. I come across the laser surgery and I decided to give it a try. And I don't regret it. I think it was the best decision I ever made for my age, and I think the outcome would be a lot more better in the future. And it was a great experience. It really was.
And you work with metal as your job, so you didn't want metal in your neck, on your spine.
No, I think the cold weather would have had an effect on it. I think it would have caused a adjacent effect, is what they call it. When you do the fusion, it make the disc below it or above it wear out. And I'm 34 years old, and if I live another 30 years, I just feel like it would cause significant problems. I think the laser is the best thing out there to have with this type of surgery. It's all legit. That's all I can say about it.
I thought he was live already. All right, welcome back. Just so you know, folks, we are having a few technical issues with our broadcasting system so that we can actually answer your questions live. I have to have you type up your questions, and I'll answer them for you at the end of surgery when I do my recap. So go ahead and type up your questions, and I'll be happy to answer them for you. Flynn is here today running the machine. All right, are we ready? So we're going to move from 6-7 up to 5-6. Everyone agree?
Agree, sir.
2, 3, 4, 5, 6. All right, here we go. Shot.
We're good, we're good.
That's it? All right, shot. Try to get rid of my hand. I don't need to have my hand radiated. Those are things you should do automatically on your own without me asking you. Shot. All right. Coming out. Right there. Shot. We're outside. I want to make sure I'm in the middle. Go ahead and give me an AP. Huh? Yeah. A little bit is fine. Right now as I navigate, it's not as important. It's a quick AP. All right, I'm a little to my side. Thank you. Back to a lateral. Now this maneuver here is the Deuk spine maneuver. It's a maneuver that I developed, and it's to be able to do multiple discs in one surgery. It was not taught to me. I created the maneuver. It's basically sliding the dilator along the front of the spine. The key here is to not lift it off the spine. Shot? Yeah, a little inline would be good, and I need an AP. If you take the dilator off the spine, then you run the risk of injuring something that you shouldn't injure. Shot. Perfect. Let's go back to a lateral. So you can see the tip of the dilator is dead in the middle of the spine, right where the spinous processes are. And on the lateral view, I think we're right in the front of the disc. We are. So it's perfect. Shot. Perfect. Shot. There we go. Let's just do another AP just to make sure. Sometimes your dilator can slip. I need a slight extension. So it would be like pull and extend. Perfect. Looks great. Back to a lateral. So we're still in the midline, in the threshold of what's acceptable. And now I'm going to bring this dilator tip to the back of the disc. Shot. Again, this is a degenerated disc, so it's pretty collapsed. People ask me, can you do this surgery with a degenerated disc? Absolutely. As long as you have a good anesthesiologist, you can. Huh? I don't think so.
Okay.
We're already back already. I think we're a little bit off on orbit. But no, I think we're good. So you can see the dilator has spread open the bones. I think I want to go a little further. Shot. All right, that's good. Now, folks, can you see this, Flynn? Hopefully you can. We're going to do the whole surgery through this tube. We made one incision, and I've just moved from one disc to the next. So this patient's having two herniated, degenerated discs fixed with one little 4mm cut. The blood loss in this surgery is almost zero. It's minimal. It's a few cc's of blood loss. So compared to an Acdf, where most surgeons lose 200 milliliters, 200, we're losing 2. So it's about 100 times less a blood loss. And there's no trouble swallowing or anything like that from the surgery. Of course, the anesthesiologist has a tube in there. That, give me a good pull. There's no scar tissue. There's no damage to the muscles in the neck or blood vessels. Shot. Watch the tip of that dilator, Luis. Shot. Give me a good traction. Now we're just gently dilating. I can feel the tube sliding nicely down. Keep an eye on the tip of the dilator.
Yes, sir.
Almost done, guys. Good traction right now. All right, almost there. Shot. Done. Good job, everybody. That's perfect. Good work. It's teamwork. Makes the dream work.
What do you think? Nah, I don't think so. No.
Don't worry about that right now. Just step back for me. We're going to get this dilator out.
You got the other one?
And Flynn, yeah, why don't you show our audience one more time how the Deuk laser disc repair works to repair the annular tear and get rid of the herniation. Can you run that video for us, for those who missed it? Type up your questions, and I'll be happy to answer them for you as soon as I'm done. We'll be done in about 15 minutes.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own and can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. We are just fitting the tube to the adapter, and because her discs are so collapsed, we're having to put a little more force onto the tool that actually pushes against the tube. And what that's doing then is it's basically bending these little ends. Let's have that dilator again. And then every time I put the adapter on, it bends it back in. So this is what we call the MacGyver moment, where, you know, this happens in surgery. Doesn't matter what kind of surgery you do. You're always going to have challenges with the equipment or with the anatomy of the patient that you have to overcome. And this is what separates good surgeons from bad surgeons. Those that are able to adapt to their environment as the environment adapts versus those that don't. And we have to adapt. We're in the middle of surgery. We don't have the luxury of doing certain things, but we have to keep going and finish this patient's surgery. We may have to change the tube out. I'm very close. But you have to get more of these tubes, Luis. How many do we have?
Yes, sir. We have at least 6 right now.
We need
Yeah.
more. The more degenerative discs we keep dealing with, the more of these situations we're going to encounter. I need you to order more. Is it that they're not producing them anymore?
Yeah, it's, I have to search for.
Yeah, I've got it
Yeah,
right there.
It's good?
Yeah, it's
Yeah,
good.
I saw that.
So it's just a matter of bending it out, but at some point that's going to fatigue and stop working. So we need to replace it. Huh?
Thank you very much. I'm good.
All right.
It's a new scope.
If you have questions about the surgery you want to ask, or anything about spine in general, we're happy to answer them. Feel free to type up your question. We're streaming on Facebook, YouTube,
Scope on, please.
LinkedIn, and Twitter. And if you're watching on any of those platforms, you may have a question, and you're welcome to ask me that question. Normally, we would answer the question during surgery, but because our microphone system is down, guys, where's the irrigation? I don't see much irrigation. Hello, ladies.
Should be fine.
We have an irrigation problem, I think. Did you switch it?
No, it's still going.
All right. It just looks sluggish. Okay.
Thank you.
And it's still working? It's why is it overexposed again?
Oh, it's a new, can you please?
Oh, a new scope.
Yeah. Can you go down, no, top, on the arrow, no, right? On the right side. There you go, up, down, go down.
Too much.
More.
Keep going.
More.
That's good.
Perfect.
That's
Thank you.
it's a little too dark. Go back one.
Thank you very much, thank you.
That's good. That should be all right. All right, very good. So we are at the back of the C5-C6 disc, and this is the herniation right here. It's calcified. It's quite a mess back here. This is what a degenerated disc looks like inside. For those of you wondering, a lot of the calcification of the herniation. The herniation is old. It's been there for a long time. The annular tear is old, been there for a long time. And the body's response is to, for some reason, for reasons unknown, is just to make it calcified. So that's why you see bone spurs. That's why you see calcification of the tissue. It's really from chronic inflammation that brings on this little bone spurs here, like the one I'm working on. And that calcification process is your body's way of trying to heal. I don't personally, or nobody understands it, why it happens. We just know it happens. It's called dystrophic calcification, if you want to look it up. Dystrophic, spelled D-Y-S. It's associated with chronic inflammation and disease conditions that cause inflammation. Remember, a lot of diseases like cancers spread throughout your body. They go to tissues and then they start to destroy those tissues. Well, as your cells are being destroyed by the cancer cells, those cells release material that stimulates your inflammatory system to respond and cause inflammation. That's a piece of herniation right there. As the tumor grows and grows, it destroys more of your own cells, and that creates more and more of an inflammatory process. There's a herniation right there. It looks like a more recent one. If I had to age it, I would say probably a year or so. So remember, herniated discs don't just happen at one time point. They're a repetitive process. I'm gonna have to grab it out. The first step in a herniated disc is to have a tear in the back of the disc. Once you have a tear, then you can squeeze out jelly. And people do. Every time you lift something or engage in certain activities, you're going to keep pushing more jelly pieces out. So most herniated discs are a series of herniations occurring over time. So some of those herniated pieces are going to be older. They could be 20 years old. Some of them are going to be newer. They could be a week old. And they're going to have everything in between. Just think about all those episodes of pain you have when you have a herniated disc. You know, maybe you had a really bad pain 10 years ago. That's when you pushed out a piece. And then you had bad pain again 5 years ago. You pushed out another piece of herniation. And every time you feel that pain flare up, you've pushed out more pieces of herniation. At some point, you won't have any more jelly to push out, but people still have the inflammation because the pieces of jelly that they did push out just sit there and cause chronic inflammation and pain. There's another herniation right there. You see it? It's literally, it's kind of like fishing. Trying to get these fish out.
From the underworld.
Huh?
From the underworld.
Fishing from the underworld.
I finished.
Oh, you did?
I cry and everything. So.
No.
Yeah.
It was good.
Yeah.
It was good. I have to admit it. We're talking about the Netflix program, Strange Things. Strange, is it strange or stranger? Stranger Things. Those of you who watch Stranger Things, a lot of our staff watch that. It's entertaining. It's good. You know, I'm going to tell you something about Stranger Things. I know that they say that these brothers created that, and I'm going to put a challenge out to any of our viewers. Did anyone notice anything in the final that stood out that was a bit of a surprise?
I mean, you mean the gay situation or what?
Huh? The what? The what?
The guy was in love with his friend or what?
No.
Oh, okay.
No, there's something they stuck in there on the last, at the end, near the end, the last 5 minutes, last 4 minutes of the last episode of season 4, Stranger Things, something quite profound. Well, basically, for those of you who like horror and sci-fi horror mystery, there's one writer who stands out above all others, who not just writes books, but actually also is involved in many movies, because many of his books have been turned into movies. His name is Stephen King. And Stephen King has been writing horror since probably the 70s or 80s. And he is the, in my opinion, as a horror expert, he is probably the best horror writer of all time. He's written books like Christine and It, and they've turned a lot of them into movies. So at the end of this season 4, in the last episode, in the last few minutes, they're sitting in a room and somebody is reading a book. Did anyone catch the name of that book? They showed it for the briefest of seconds, and only a true Stephen King fan would know what book that is. It was written by Stephen King and Peter Straub, another horror writer from the late 80s, early 90s. Anybody know? Well, I'll tell you. It's called The Talisman. Has anyone read The Talisman? I've read it a few times. It was written by King and Peter Straub. It's an incredible adventure about a young man trying to save his mother from dying of cancer. And of course, he goes into other worlds and meets creatures and monsters. But it's a hell of a journey and a fantasy. Point is, I have a feeling Stephen King had something to do with the Stranger Things.
Come on, please.
As a matter of fact, he may have had it ghost written by these
Stay there
brothers.
because we're gonna go back. Yeah, stand by. Yeah. All right. Again. Now we're here.
Either that or the brothers who created Stranger Things, basically paid tribute to Stephen King. I'm not sure. Huh? They're probably huge fans of Stephen King. I agree with you. But I don't know. Stephen King does subtle things like that in his movies. Sometimes he'll put himself in the movie. You won't even recognize him. He's done that in many movies, like It, or Creepshow. Huh? But the storyline of Stranger Things is kids fighting evil, right? From another world. It's the same as It. It's the same as almost all of Stephen King's books. It's basically empowering children to take on their monsters together and overcome evil. It's so in line with Stephen King. Yes. I only need about 5 minutes. Why? Yeah, if you do. Appreciate it. Yeah, but I need about 5 more minutes. I'm still not done with this. Anyway, I just thought that was interesting. I don't know if anybody knows anything out there that I don't know, but when I saw the talisman in the hands of that character, and they were all reading it together, I thought maybe Stephen King had something to do with this series in terms of helping create it.
Maybe he was kind of a consultant.
Could have been a consultant, could have been just like Monica said, I think, or somebody said, that he was an inspiration to what's the name of the guys that supposedly did Stranger Things? The Something Brothers? The guys that wrote Stranger Things or directed? Duffer Brothers, that's it. Yeah. I don't know, I think there's something there. Something to do with Stephen King. He ghost writes quite a bit. I don't know if you guys know that. He writes under different names. So, I remember while I was watching Stranger Things thinking, so much like Stephen King, the storyline. This is a total Stephen King story. And then to see that Talisman book at the end is incredible. Anyway, all right, Dr. Deuk Majan, we're just about done with the Deuk laser disc repair. We're finishing. That's another herniation, by the way. That's what they look like, little cotton balls. The laser is up there at 12 o'clock. You can see how it's used to release pieces of herniation. We wouldn't be able to do this surgery without the laser. There's no instrument small enough to do all this except for the laser. So the laser is essential. This is the neuroforamen over there at C5-C6 on the left. I've already been over to the right side, cleaned it out, and I just want to make sure we get any and all herniations over there in that foramen. So that's the right C6 nerve root will be just underneath there. This is what's called foraminal ligament. And you can see it's calcified. That's where that golden color is. It's calcium. And you can see the fibers of the posterior longitudinal ligament down there. We're not going to mess with them, but we are going to peel everything off above them because that's where the herniation is. There's some fibers. You can actually see a hole there in the PLL where the herniation went through. So I got to get rid of that. I'm going to flip it. We're just about done, folks, and I'll be happy to answer any questions you have if you type them up. That way Flynn will read them off to me and I can answer them for you live at the end of the surgery. But so far everything's going well. This is a degenerative disc disease, in case you're wondering. This surgery works for bone spurs, herniated disc, degenerative disc disease, stenosis, spondylosis, bulging discs, ruptured disc, protruded disc, slip disc. So many different names to describe really the same thing. This part here is stenosis or narrowing. Once again, you can see the fibers of the PLL. Piece of herniation there. I just blasted it up into little bits. It was hiding there. There's another herniation that just came out of the frame. You all see that? It literally shot out. And by the way, that's not possible without the laser, in case you're wondering. The laser is essential. I love it when surgeons who don't do laser surgery try to tell us that laser is not necessary. It's just a gimmick. It's not a gimmick at all. If you watch the surgery, you'll see that if I take the laser away, I'm not doing anything. There's no point in even doing the surgery because it won't work. So the laser is essential. All right, we've looked across the disc side to side. I'm not seeing anything else. I am going to take one more peek. Laterally, you okay, doctor? And our patient is stable. She's doing phenomenal from a anesthesia standpoint. Remember, she's asleep, okay? She has a tube down her throat, so we've secured her airway. That's absolutely necessary to get the surgery done. All right, we're done.
All right, nice one, please. Go out. Thank you.
Hope you enjoyed this 2-level of discs, Deuk laser disc repair. Can you see, Flynn, the tube here? I hope you can. But basically, that's a little antiseptic. We give it at the end of the disc repair. That way we don't ever have any infections. We're going to irrigate it out now. It's actually betadine, which is commonly used in surgery as an antiseptic. Developed by NASA, which is just literally down the road, 10 minutes from us. And it's the best antiseptic we have available. That's why we use it. It's very safe as long as you don't have an iodine allergy. All right, can you see this, Flynn? I hope you can. I'm going to show you the tube here. It doesn't want to come off. That's good, though. We'll keep it on. All right, tiny little incision. It's 4 millimeters. We're going to take this tube out because we're done. Literally just pull it out of the disc. I'm going to apply pressure in case there's a little venous bleeding. We never have arterial bleeding because we're not entering an artery. And sometimes you'll get a little vein that gets torn during the surgery. Most of the time we don't have any veins. But you want to apply pressure for a couple of minutes in case you have some venous ooze. All right, don't forget Deuk Spine Institute has an app online. You can get it on your iPhone or your Android, and it's called the Deuk Spine Institute app. It only costs $10,000. Oh, no, it's free. Sorry. It's free. And you're welcome to download it, put it on your phone, and you can have access to all kinds of good content explaining different conditions like herniated disc, spinal stenosis, facet syndrome. Also allows you to submit your MRI for our review. You can actually see the artery pulsing right there, called the carotid artery. You all see that? Pretty cool. All right, let me show you the incision. 4 millimeters right there. And you can see the neck is supple. There's no blood clot. We'll hold another minute and then we'll put a steri strip and a Band-Aid. This is outpatient spine surgery, folks. Acdf, very invasive surgery. And once again, why don't you show the comparison video, Flynn, between Acdf and Deuk laser disc repair so people can appreciate the difference.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a ½ inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's half-inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful.
You're watching a patient who just had surgery on their spine through the neck. There's two ways to get to the spine through the neck, and if you imagine this is the spine and the neck, forget about the metal plate and the screws and rods. Just focus on the spine itself. You can go through the front or you can go through the back. By far the best way to fix a degenerated disc, herniated disc, bulging disc, spondylosis, stenosis, radiculopathy is always going to be through the front. Why? Because the cause of those symptoms of neck pain and arm symptoms is almost always a herniated disc or pinched nerve. And the herniated discs are always in the front of the spine. So if you think about the spinal cord being the most important structure with the nerves coming off, there's things in front of the spinal cord, that's your vertebral body, your disc, and then there's things in the back of the spinal cord. That's going to be your spinous process, your lamina, and your facets. So the best way to fix any condition that has to do with a disc problem is always through the front. There are surgeons now that go through the back and they drill holes. They call it a laminotomy. Bad idea. I've seen so many bad results from those surgeons. It makes my head spin. Stay away from the posterior approach. It's bad, bad, bad. The only time I ever go in the back is when I have 4 levels of narrowing discs in the front and the patient's not having laser surgery, they're going to have a fusion. Then I go through the back, I do a laminectomy, and I do a fusion. And I use these here screws and rods right there, and these are called lateral mass screws, and these are rods. You do them on both sides. I'll do that from C3 to T2, okay? But that's a rare case, and otherwise don't let people go through the back of your neck if they're not going to do a laminectomy and fusion. There's a laminoplasty procedure that's done for multi-level stenosis. I don't recommend it because there's so many complications from that surgery. Again, if you get to know me as a surgeon, I'm all about results. You know, results, results, results. That's what matters. So no complications, high results with respect to eliminating pain, headache, pinched nerve symptoms, and the very best surgery for all of those things on every count is the Deuk laser disc repair. Okay, I've done all the other surgeries, artificial disc, ACDF, with or without plates, with or without grafts, with cadaver bone, without, with corpectomy, with strut grafts. I've done it all, PCDF, foraminotomy, and comparing all of those surgeries to each other, there's one that literally stands out. It's not even in the same area code, zip code. It is the Deuk laser disc repair. And it all starts with endoscopic spine surgery done through the front with a tiny little cut like you saw, 4mm incision. What have I done different? Number one, I put people to sleep. Why? Because if you look at how the Koreans, who really pioneered the anterior cervical endoscopic transdiscal approach, if you look at how they do their patients are awake, all right? And they are literally squirming around while they're going in, and they're like, ah. So that's dangerous. You could poke something you shouldn't poke. So immediately, the first thing I did different from the Koreans is to knock the patient out completely with general anesthesia. That allows me to give a muscle relaxer so the muscles don't tighten up. That helps me to feel the spine better, so I know exactly where I am with that needle when I go in. It makes the surgery 1,000 times safer. The Koreans argue, well, if the patient's awake, they can tell you if you hit something. Well, they're not going to tell you if you hit their carotid artery. They're just going to have a stroke and die. So that's what you have to worry about: esophageal perforation, carotid artery injury, jugular vein injury. Of course, you have your sympathetic trunk. So all those things, the patient's not going to tell you anything. All right? You can actually go right through the spinal cord with your tube and paralyze the patient, and they won't say anything. Why? Because the spinal cord doesn't hurt. It doesn't have a innervation. So it's important that you be smart about how you approach these surgeries. I use general endotracheal anesthesia with complete neuromuscular blockade, and I can feel things the best that way, and that way I have the safest. I use the x-rays to navigate. I use the x-rays to localize. You saw that during the surgery. You can notice if you watch my surgeries, I do it exactly the same way every time. Why? Because once you have the very best way to do something, you want to repeat it over and over and over again. That's what surgery is. The best surgeries in the world are those that are reproducible, and they give you the same exact best result. All right, let's take our first question.
Perfect. The first question is going to be from Gail from Facebook. And
Hi,
they're
Gail.
And they're asking if there are some desiccated discs. Does this change the game plan for candidacy for a Deuk endoscopic laser disc repair?
Well, Gail, great question, and thank you for asking. So I recognize that people get confused with all the terminology out there. Gail's asking about desiccated disc, and a desiccated disc is a dried out disc. Basically what Gail is acknowledging, and it's true, you have to pay attention, it's important. I'm going to grab one of my models here. The disc is actually a cushion between the two bones or vertebral bodies, okay? It's a joint and it moves. And the disc has two parts. It has an outer wall and it has a jelly center. Desiccated discs are when the jelly center gets dried out, okay? So think of it like toothpaste, where the toothpaste is nice and moist with lots of water at first, but if you leave the cap off, it gets dried out and it becomes firmer. So a desiccated disc is basically a dried out nuclear material or jelly in the center. The Deuk laser disc repair can still be done very successfully, equally successfully, whether the disc is desiccated or not. And the reason is that it has nothing to do with the desiccated disc that causes patient symptoms. Patient symptoms come from the tear in the back of the disc. Let me show you one of these discs and that'll make sense. If you look at this thing, this disc has a jelly center which is colored red, and it's got a wall around it called the annulus, which is this lighter color. When you get trauma to your disc and you tear the back wall, that allows the jelly to push out through the tear, and that's where you get the herniation. The Deuk laser disc repair targets not the desiccated jelly, but the herniation and the tear. It has nothing to do with desiccation. And the pain people have nothing to do with desiccation. There are so many people, millions upon millions, literally hundreds of millions of people in the world over the age of 40. They all have desiccated disc. They don't have any symptoms. We leave them alone. The Japanese did a study. They took 1,000 people off the street with no neck pain whatsoever. None. Never had neck pain, never had arm pain, totally normal people, normal with never a neck problem in their life. They got MRI scans of every one of those 1,000 of their cervical spine. Guess what they found? Herniated disc, degenerated disc, desiccated disc, bulging disc, 90%. That's 900 out of 1,000. But they had no symptoms. Is this new to me? No. Spine surgeons, we all know this. We all know there's lots of people with desiccated disc, collapsed disc, bone on bone, you know, call it what you want, spondylosis, stenosis, but they have no symptoms. We don't treat those people. We don't offer them surgery, we don't offer them shots, we don't offer them anything because they're normal. And so it's not the desiccation that causes symptoms. It is an inflammation in the posterior tear. We showed you that video during the surgery. Go back and rewind it and you'll see it. We discovered that here at Deuk Spine. That is why we're the only ones that can cure people's neck pain with surgery, because we know exactly where the pain's coming from. And it can be reached with the laser endoscopically. Next question
is from Santosh from Facebook.
Hello, Santosh.
And they're asking, do you do post-op MRIs?
Santosh is asking, do we do post-op MRIs? No. Unless the patient's having a recurrent disc herniation, there's no reason to get a post-op MRI. We're not treating an MRI. That's one of the biggest mistakes people make. They think an MRI is important. It's not. What's important is the patient. The patient's symptoms should go away with the right treatment. Okay? If you have the right treatment, the patient's neck pain will be gone. Their arm pain, gone. Numbness, tingling, and weakness almost always will be gone, as long as it's not permanent nerve damage because they waited too long. That's typically what we see. When we have a patient who has the laser surgery and they continue to have pain, it's always from something else other than the disc that we fixed. And it's just a matter of figuring out what it is. It's usually the facet joints that cause that pain. So if I do this lady's surgery, she still has pain. I know, for example, on this case, she has a C1, C2 instability. We've already diagnosed it. She has herniated disc causing problems. She has C1, C2 instability causing problems. She chose to get the herniated disc fixed first. We know she's still going to have pain higher up at C1, C2. We didn't operate on C1, C2. We operated on C5-C6, C6-C7, not C1, C2. For those of you who don't know the difference, 5, 6, and 6, 7 is this disc and this disc. C1, C2 is up here. Okay? The only way to fix C1, C2 instability pain is to put in screws and rods up here. That's next for her. I think she wants her back fixed actually next, and then she's going to have the C1, C2 fusion done. So my point is simple. Don't treat MRIs. MRIs are not important. MRIs never show you where people's pain's coming from. The patient will show you where their pain's coming from. They will point to where it's coming from. And that is one of the biggest problems in spine care today, is everyone's looking at the MRI and not looking at the patient. That's what makes Deuk Spine better, is we don't just look at an MRI, we look at the patient. For all of my telemeds that I do, the virtual consultations that are free, they're available at Deuk Spine Institute. If you have an MRI and you're having pain, sign up for a free consultation. You will see that I do a Zoom meeting face-to-face with the patient. I have their MRI here, I have the patient here, and if the patient's telling me they're having pain here, I look at the MRI and I line up where their symptoms are versus the MRI, and I can figure out what's wrong. But at least 50% of the time, if I just look at the MRI and say, oh, we're going to fix this, this, and this, and then I go talk to the patient, they're not having pain there. So there's no point in fixing those discs if they're not having pain from it. You've got to go to the source of pain. MRIs don't tell you where the pain comes from. MRIs show you structural abnormalities. Like I said earlier, with the Japanese study, 1,000 patients, 90% had herniated disc. They have no pain, no symptoms. So you can't be looking at an MRI. You got to look at the patient. That's the biggest mistake made today. And when I was in medical school, that's what I was taught. I was taught, yes. I hope this is important.
It is. Barbara from Boeing called and said that Dr. Barnabas is not correct.
Sorry about that. Just come see me after I'm done. what we're getting at here is that you have to treat the source of pain, and determining the source of pain is a clinical diagnosis. It is not a radiographic diagnosis. So I know all my colleagues are caught up in making x-rays look good after fusion or artificial disc, but that's not important. What's important is the patient and what they experience. If I can cure their pain, I don't need to be seeing an MRI scan afterwards, okay? And as I was saying, my medical school taught me the art of the physical exam is lost among our contemporary doctors. Our contemporary doctors today rely too heavily on tests. They don't rely on the patient exam. The patient exam, I have found, is the key to fixing back and neck pain. And the reason why there's so many people living with back and neck pain is their doctor can't figure out where it's coming from. And the reason the doctor can't figure out where it's coming from, number one, they don't have the experience to figure it out. But no, number two, they're not doing the physical exam properly. Okay? Next question.
The next question is from Star from Facebook. And they're asking, what is the long-term results after the surgery? More needed in the future?
Yeah, great question, Star. Thank you from Facebook.
Correct, from Facebook.
Yeah. So Star, the long-term results, we did this surgery for 16 years. The people that had it done 16 years ago have no pain. They're doing great. We have data to show that 6-year average follow-up, 6 years of follow-up. So the patient had surgery, and what we said was, okay, we're going to take all the patients that had it on their lower back, and we're going to make 5 years after surgery the cutoff to be included in looking at those patients. We call it a cohort. So we took people that had surgery at least 5 years ago and further out, and we looked at their results. And the average follow-up time was 6 years for that group. Of course, you think it's 5, but it's not 5. It's actually 6, because we had 5-year-old, 6-year-old, 7-year-old, 8-year-old. When we took those people and looked at how much pain relief they had from this surgery, 95% of their back pain was gone still at 6 years out on average. 95% of their leg symptoms were gone still 6 years out from surgery. So the long-term results are phenomenal. Certainly better than fusion or living with the pain, which the long-term results are terrible if you're taking pain meds. You're still going to have the pain. Long-term results are terrible if you're getting shots. You're still going to have the pain. Long-term results are terrible if you're having fusion. You're going to have more problems down the road. Artificial disc, same thing. By the way, a study just came out showing that the adjacent segment disease rate for artificial disc surgery is the same as it is for fusion. So the whole point in having artificial discs was to prevent adjacent segment disease. That's how they sold those discs to everybody. But it turns out that the people who have artificial discs, long term, they have the same rate of adjacent segment disease as fusions. May come as a shocker to you. I didn't publish this. This was just published 6 months ago in a scientific journal. We have it all over our Facebook page. Great question, but the long-term results are the best for the Deuk laser disc repair.
The last question is from Beth from YouTube, and she's asking what happens after surgery if you have to remove all the disc.
Hi, Beth. What happens after surgery if you have to remove all the disc? Great question. We never do. I've done 1,500 surgeries. There's no reason to remove all the disc. There's absolutely no point. All we're removing is the herniation, and we're cleaning up the herniation that's stuck inside the tear in the back of the disc. That's it. So we're removing, we've actually published this. If you want to look at one of our papers from back in 2012, we are taking out 5% of the disc. And we're not even taking out this part that's normal or that doesn't cause problems. We're taking out the part in the back, the herniation, and it represents 5%. But it's the bad 5% that we're removing. Great questions. Hope you enjoyed the surgery. We'll be back in 30 minutes for another Deuk laser disc repair. This patient has coming to us from New York down to Florida for the Deuk laser disc repair. He's got 3 herniated discs in his back, L34, L45, L5S1, and it's causing horrible back pain and pain down into his right leg. So we'll be doing the endoscopic Deuk laser disc repair on his lower back, and that's going to start in about 30 minutes. So go grab some popcorn and a new soda, and we'll see you soon.